as all of the other presentation. So that said, the podium is yours.
All right, thank you, Professor. So again, good day, everyone, and welcome to DCB Academy activity today. So we are pleased to have Dr. Bharat Kialani from Singapore, an interventional cardiologist and a valued member of DCB Academy. He will be sharing his insights on active side branch protection and provisional stenting. So Dr. Bharat, thank you for taking the time, and the floor is all yours.
Thank you, Iman, and thank you, Prof, for allowing me to give this talk today. So I might just share the screen if that's okay.
Yeah.
Can you all see my screen? Can you see my slide?
Yes, we can see it, not in a presentation mode yet.
Is that better?
That's
okay.
Perfect.
So the idea for this, I think Iman kind of asked me if I would be willing to talk about this sort of active side branch protection in provisional stenting. I think I posted a few cases on our WhatsApp where I do provisional across major side branches and kind of protect it. And so, I've done a little bit of reading about it, and then she kind of suggested that maybe we do this presentation so then we can have a discussion. I can show you some cases and some evidence of why I think it's a good technique to learn to help to simplify bifurcation PCI with a provisional strategy. The idea is to be as interactive as possible, so I'm happy to be interrupted at any time. I've kept it nice and short so that we can have time for discussion as we go through the slides. So we know that coronary bifurcation, you have a flow divider, so the carina, and three vessel segments. So this is just some revision. You've got the proximal main vessel, the distal main vessel, and then you've got the side branch. And there's a constant relationship between all these three vessels that was identified by Murray's law, and that was more than 95 years ago. And Finet actually described how to measure these vessels using IVUS. And so we all know this formula of Finet's formula, where you have the diameter of the parent main vessel is 0.68, or about 2/3, multiplied by the diameter of the daughter main vessel plus the diameter of the side branch. And this is how we decide.
I have a question, Bharat.
Yes.
Yeah, we all cite Murray's and Finet formula. My question is the Finet one, which is more recent. So it was based, as you correctly said, on IVUS, but did they measure the lumen? I think they used, I'm not sure, but this is part of my question. They use normal coronary arteries and not the diseased coronary arteries. But the second part of the question is, yeah, did they use the lumen or the vessel itself from external elastic lamina to external elastic lamina?
So that's number one, that's correct. They used normal human coronaries, and they used vessels with plaque burden of under 30% on the IVUS. And my understanding is that they actually looked at the lumen. So this was quite early on. And I think IVUS technology back when they used it was not as good as it is now. So they used the outline of the lumen, and they assumed that these were normal coronary arteries that had some very minor plaque. And because angiographically they couldn't see plaque. And so then they assumed that the IVUS lumen was a measure of normal.
That makes sense. Thank you.
So this is what we tend to use whenever we do kissing balloon, for example. When you choose your sizes, technically you're supposed to, to use Finet's law, but maybe many of us don't do that. But, it's one of the teachings that we get as junior registrars and fellows coming through. So how then do we define bifurcation disease? So when you have a lesion in a major epicardial vessel, next to or including the ostium of a side branch, that's considered bifurcation disease. And a significant side branch is a branch whose severe narrowing or occlusion before or during intervention can cause significant ischemia or infarction. So really, anything that you think can cause either pain, ischemia, infarction to the patient is deemed a significant side branch. But there are some other important elements that are not inherent to bifurcation classifications, and that's the extent of the disease on the side branch, the size of the side branch, the bifurcation angle, and the disease distribution. A bifurcation coronary stenosis is usually a stenosis involving or adjacent to the origin of a side branch more than 2 millimeters in diameter. Some people say more than 2.5, but there are some that actually say anything more than 2, you can get ischemia, peri-procedural troponin rise that resembles an infarction. And the stenosis can either involve a large branch, such as a circumflex artery, or it can include a small branch, such as a diagonal or obtuse marginal. So then how do we classify bifurcation disease? There are various angiographic classifications, and the most common one that I think all of us are quite familiar with is the Medina classification. And really, this classification is just established on the presence or absence of stenosis. So if you have stenosis that's more than 50%, that's considered present, and it's given a score of 1. And if you have stenosis that's less than 50%, then that's considered absent, and it's given a score of 0. So most of you will be quite familiar with the Medina classification. There are some other classifications that are not so commonly used, but some of you may have heard of them, the Dew classification, the syntax classification. But like I said, the most common one is the Medina classification. The most important distinction is to actually divide bifurcations, I think, in my opinion, into true bifurcations. So where the main branch and the side branch are both significantly narrowed, or non-true bifurcations. And really, this will influence how we plan to treat these complex lesions. So Medina 111, 101, 011, they are classified as true bifurcations. And there are some other criteria that have more recently arose, particularly the definition criteria. And this is very big in the sort of Asia-Pacific region, predominantly coming out of Korea, where you have this major risk factor and minor risk factors. And really, it allows you to then differentiate between true or complex bifurcations or non-true and non-complex bifurcations. And that would eventually influence your strategy in how you treat these lesions. There are some guidelines and recommendations as to how you treat bifurcations. People in Asia tend to treat it differently from people in Europe. We have the European Bifurcation Club, which has its own set of recommendations. In the Americas, there's another set of recommendations. And for us, more relevant, we have DCB believers and DCB gurus. And we have our own approach to dealing with bifurcations, whether it's a DCB in the side branch or a DCB in both the main vessel and the side branch. And there is some emerging data and projects underway to look at this as a viable treatment strategy. But the key message in bifurcation PCI is that less is more. Provisional stenting tends to be more in fashion these days, and the reason is because it does translate to improved clinical outcomes. So, is there any way that we can actually enhance the provisional approach? In the past, I'm pretty sure most of us would use either a jailed wire or putting a sort of balloon in the side branch, but there are some additional techniques that we can go through. And some of these techniques I will describe in a bit more detail and show you some cases as to how we utilize these techniques for significant side branches. So the jailed wire technique, it's pretty simple. You kind of just leave a wire across the side branch. You deploy your stent in the main vessel. You do a pot, and then you post-dilate as required, and then you're done. The second figure here shows the conventional jailed balloon technique. Now, this is a technique that was described by Francesco Burzotta, and really what it involves is the protrusion of a side branch balloon proximal to the stent edge. So you put an uninflated balloon extending from the side branch to the proximal stent edge, and you leave it there. And this next figure kind of shows it. And then you inflate the stent with the balloon there, remove the balloon if you don't have side branch compromise, and then do your pot and post dilatation as you would normally. So you're basically increasing the profile across the side branch. In addition to the wire, you have an uninflated balloon. The contemporary gel balloon technique, which is a variation of the gel balloon technique, uses a similar concept, but minimizes the protrusion into the main vessel. So really you have an uninflated balloon just sitting across the ostium, and it sits there while you inflate your stent, pot, and post-dilate. There are some more newer techniques, the modified gel balloon technique, which involves inflating the side branch to avoid the carinal shift. The ATP, or active transfer of plaque technique, where you actually inflate the side branch balloon first to ensure any plaque is pushed away from the ostium of the side branch, and then you deploy your stent, or the gelled microcatheter technique, which really is just a wider lumen across the side branch. The key points that you need to know with all of these techniques is, number one, there is an increased risk of side branch entrapment. However, in all the reported cases, there has not been one reported case of an entrapped device if the balloons are removed before you do the pot. And usually if you do a good pot, there is very minimal stent deformation. And I will show you some IVUS evidence of this, where I actually deployed the stent with the gel balloon and then removed the used balloons, did IVUS to show the amount of deformity, then did the pot, and then repeated the IVUS to show the correction of that slight deformity. Now,
Yeah,
with all these...
Marat, we have to underline the fact that all of these techniques, I agree with your points. So I'm not worried about the stent deformation. But all of these techniques require expertise in bifurcation lesions. I mean, to start applying this technique, you shouldn't just do, simple PCIs. You should be, in my opinion, an expert in dealing with dual stenting, with culotte, crash, and a complex scenario with some atherectomy. Because, for example, theoretically, there is no case report of entrapment, but if you don't do it correctly, the risk of entrapment of the balloon, of the microcatheter, can be there. There is also a theoretical risk of the dissection of the ostium of the vessel. If you pull too much, too hard with a guiding catheter. So all of these things probably are not an issue if you are an expert interventional cardiologist. But if you are at the beginning, I think that you should first of all learn the basic techniques for complex PCI and bifurcation before jumping into this technique. Which are your thoughts about that?
Absolutely. I think, the most important thing is to keep it safe and keep it simple, as simple as you can. Now, these are more advanced techniques that, throughout your career, you might learn and be able to employ. But of course, when you're starting off, just be safe. Usually start off with a simple wire across, recross if you need to. You got pinching of the side branch, recross, do the standard things of kissing balloon. If you do get dissection, you might need to learn your bailout strategies in terms of how do you then convert to a two-stent technique. What sort of bailout strategies do you have, whether it's a tap or a culotte or a reverse crush. These are techniques you need to be quite familiar with, of course, before you start engaging with this slightly more advanced techniques. And yes, you're right. When you do withdraw the balloon, there is a little bit of resistance as well. So you have to keep an eye on the distal wire. You have to keep an eye on the guide to make sure it's not diving in. And if you're doing something that's, involving the left main, for example, then you probably want to avoid LSD of the proximal stent edge as well, by the guide kind of hitting it. So there's a lot of technicalities to it. And it might sound, relatively simple and easy to do, but of course, the basic fundamentals of PCI is keep it safe, first of all, as simple as you can. And then these are slightly more advanced techniques you can employ as you progress throughout your career.
Yeah.
In terms of the balloon sizing, it would depend on which technique you employ.
May I ask, sorry to
Yeah.
interrupt you again in this point.
No problem.
May I ask, I want to ask one question at this stage. If there is a, we are placing the wire inside the side branch and we just want to do dot and pot, to be very precise dot and to be very precise pot. Maybe one stent stud or two stent stud may be under expanded. Do it works like this if you are if we are using, in spite of more advanced technique rather than more advanced techniques, will be becoming more conventional in this stage? How do you have you any experience for this?
I don't understand dot and pot. I mean,
Yeah,
well, what is
dot
dot and
dot is the distal optimization. Like
oh, right.
if you
Okay.
just placing the balloon wire in the side branch and just do distal optimization to that wire side branch, and pot like a proximal optimization. So in this way we are having a only one stent stud or two stent stud length, which may be under expanded, but other you are having a good result with the stent.
Yeah,
So
so I think that's where you know your imaging before is quite helpful. So you need to match your stent, of course, to the daughter main vessel. You need to try and get as close as you can in terms of sizing. And yeah, then of course, some people do use these techniques and do a distal optimization with the jailed balloon still in. I tend not to do that. I'm always quite concerned about leaving the jailed equipment when you're post-dilating, just in case, you know, you kind of entrap it. So I tend to remove it and then do a pot. We do now have these specialized pot balloons. So we have this pot PTCA balloon, which has no shoulder, and you basically can line up, you know, right across the ostium of the side branch, do your pot, and you tend to get a very nice optimized stent proximally.
yeah,
Which is what we tend to use these days, especially if you're dealing with a large, medium or large size side branch. And then, you know, the other thing I tend to do is a proximal post dilatation first, because there is some data that if you do a distal to proximal post dilatation, you can get, depending on the stent that you use, some elongation.
yeah,
Of the stent. And I mean, we publish in Jack Interventions, you know, a little sort of images thing. You can get up to 2.3 millimeters of elongation if you do a distal to proximal post dilatation, depending on the stent you use and depending on the length of the stent. So, I mean, 2.3 millimeters, if you have it progressing proximally, you know, if you're dealing with an ostium, you might protrude quite a bit. So a lot of the time I like to do a proximal post dilatation first to anchor that proximal stent strut, and then do the more distal post dilatation afterwards.
yeah, I see. Okay. Thank you.
Okay, so just going into the first case example. So this is a 46-year-old male, anterior MI. He was quite unwell when he came in. This was his ECG. His ejection fraction was reduced, and he had multiple regional wall motion abnormalities. This was his angiogram. So he had a CTO of the right coronary artery. And then this was the left coronary system. So a completely occluded proximal LAD. He's got sort of moderate plus disease of the circumflex, osteal circumflex. And so I wired both and then just did a POBA. And this is what with the 2.5 compliant balloon. And this is what we had after we did a POBA. So we restored flow. Hemodynamically, he became better. There is a lesion in the mid to distal LAD. The original lesion, we have POBA'd it. And then you've got this sort of osteoproximal circumflex lesion where, you know, if you're going to stent across that, what's going to happen? Is that going to pinch a bit more? What's going to happen to it? It's a very big circumflex OM system. And we know he hasn't got a right coronary artery. So it's an important territory. So what next? Do we stop at POBA, refer him to cardiothoracics? Do we stent everything, or do we consider a hybrid approach? And I decided to undertake a hybrid approach. So
Why do you ask this question?
Yeah, it's interesting. It's interesting because, you know, sometimes in the past, I think some practitioners may actually stop here and say you've restored the flow. You've now got TIMI-free
Yeah.
flow. You've got a chap who's young, who has triple vessel disease. Do you stop and send it to your surgeon? And I'm sure the surgeon will be very happy with you because there's a nice graftable target. You know, young patient, not too much in terms of comorbidities.
Yeah.
The
Yeah, but
usually
there is a lesion in the distal LED. I mean.
there is a distal yeah, there is a lesion there, which is why I kind of circled that as well. So
Yeah.
maybe the LAD graft, they'll probably have to place it quite distally. But so we decided to just take a hybrid approach. So I pre-dilated the circumflex, the osteal circumflex, and then treated it with a drug-coated balloon. And this was the vessel after a 3-0 scoring balloon, and then 1-to-1 or maybe slightly undersized, just to avoid dissecting it.
Yeah.
A 3-0 drug-coated balloon. And it looks much better than it did. And so then decided to work on the LAD. So pre-dilated with the scoring balloon, treated the mid to distal with the drug-coated balloon again, hoping that, if he does have a need for future grafts, we've maintained that and we've restored some anatomy there. And then decided to stent across the left main with this contemporary gel balloon technique. So leaving the balloon there, a provisional approach like is recommended, not inflating that side branch balloon. We've treated it with the drug-coated balloon, a paclitaxel drug-coated balloon, and then stenting across the carina with a single drug-eluting stent. And this was the final result. So it was provisional with a pot, and it looked okay. TIMI-free flow. The mid looked a bit of a recoil, but we started to see collaterals from the septals going to the right coronary artery, so we're quite happy there. And this time he was, clinically much improved, so I decided to stop there. And the IVUS confirms that the stent was well expanded and well opposed. A little bit of recoil in mid to distal, but we left it. So I brought him back to do the right coronary artery. We had a discussion, and this was the left system. So you can see the area that's stented looks well, like we left it. It looks well expanded. The stent is good. But look at the osteal circumflex, and the mid LAD has remodeled a little bit as well. So maybe we had a bit of spasm at the time of the index, but we do have a very nice mid LAD, and the osteal circumflex is widely patent.
Yeah, the result is excellent. Two questions. Which technique did you use to recanalize the right?
Antegrade wire escalate, just Gaia next. I use a Gaia next 2 or 3, I think, to just get through, and then I think I hybrid DES DCB DES in the CTO body proximally, and then DCB all the way into the I think it was the PDA. I didn't put the pictures here because it wasn't relevant to talk, but
no, because there is also this juicy retrograde collateral.
yes.
But
I know that.
I agree that this is an antegrade case to start with for sure, 100%.
And with wire escalation, it went quite nicely. I mean, it wasn't too calcified. He is relatively young, so it was quite okay to get through. And then the good thing about just stenting to the very proximal LAD is that septal is still available should you fail an antegrade approach.
Yeah. Now, this is an excellent result. Second question. Have you ever jailed a DCB?
Yes, I've actually submitted to Asia Intervention, and they've accepted my my case. It's a case and a step-by-step. It's called they asked me to name it JDT, jailed DCB technique. So I've done about 35 now, and it's been submitted to Asia Intervention. They got back to me, and I've made the revisions, and the publication should be out soon.
Nice. All right.
And it's really similar concept. You prep the side branch, and then you rather than using a compliant balloon, you use a DCB, and you inflate the DCB first. And when you're 45 seconds done, then you inflate the stent. and then deflate the stent balloon, deflate the DCB, remove the DCB, do the pot, and the results are quite nice. I also did some bench model testing with the heart models and showed that the deformity is quite minimal. And I've also done some electron microscopy work to show the polymer damage there's no real polymer damage. So that I will follow up with the second publication. But I'll send you the manuscript. It's just a very small, I think it was 500 word for Asia intervention.
Okay. Nice.
Okay. So you can see there the circumflex looks good. The LAD, now you have a future Lima target. And you know, he's doing really quite well. So what is the evidence for gel balloon technique? Now, this review article came out of Wakas's colleagues from Pakistan. This was in 2020, it was published. And they really looked at the literature of all these techniques and showed, you know, comparison between the conventional, the simplified, the semi-inflated, the modified, the balloon stent kissing technique. So there's various different gel techniques that have been done. And a lot of them varied. A lot of these studies vary in terms of the vessels that were treated. For example, the simplified gel balloon didn't involve left mains at all. Whereas the conventional gel balloon, modified gel balloon by Saito, they included left mains, just like how I showed you the case earlier. And in terms of procedural success, all of these you know, publications had 100% success. Of course, the numbers in some of them are not so big, but then you had Saito with 254, Kaili with the Turkish group with 150 cases, and you know, good TIMI3 flow after the procedure in the side branch, very little so in terms of complications, and like I mentioned, entrapment across multiple of these registries and studies being 0%. So I just wanted to show you a second example. So this is again with the non-inflated technique. So 64-year-old exertional angina, positive stress tests, and then he had this wraparound LAD, which I pressure wired, and it was positive. And this is the IVUS. I have a new toy in my cath lab, a NERS IVUS, so I've been playing a lot with it to do pre and post DCB and pre and post stenting and pre and post prep. And it's quite a fun toy to play with, but really I'll wait for the section just distal to the diagonal. It's a bit of a long run. But here you see the plaque starting to come in, and then as we get towards the diagonal, you do have plaque there that's quite calcified. You have some nodular calcium. And then areas of 270 of calcium, some nodules there, eccentric, more calcium proximally, and then a healthy landing zone in the proximal vessel. So in this case, I decided to use orbital atherectomy. So we did some runs of orbital atherectomy, and this was the vessel after. Technically, you know, I should have DCB'd both of this, but I decided to stent this and then just gel balloon across the side branch. So this is the positioning. So you first put both equipment in situ, then you pull the drug coat, the gel balloon back into the main vessel with some minimal protrusion. I mean, the degree of protrusion can vary depending on your comfort level. Now you're not inflating the balloon, so you can place it, you know, sort of just inside the stent. And then deploying. This drags a little bit. But you basically then leave the gel balloon there across the ostium and you deploy the stent. And this is the IVUS after the gel balloon. And what I want to show you is at the area of the bifurcation, The calcium is all nicely modified. So here at about 4 or 5 o'clock, you see the side branch wire coming. So this hasn't been potted or post-dilated. I just wanted to show you how much deformity you get by using a gel balloon. And really, it's quite minimal. You see the side branch wire come in, and now you're in the main vessel. So very minimal in terms of stent deformation, and the balloon really slips out very comfortably. And then you go on to do your post-dilatation, pot and post-dilatation. And then here's the final IVUS, just showing the correction of the proximal under expansion and malar position, and everything looks well expanded. That's the procedure done. And angiographically, you can see the side branch looks widely patent. So there are some concerns, like Prof mentioned. It does increase the complexity. There is the risk of balloon entrapment. You can get stent deformation. There is side branch vessel dissection as well, particularly if you're going one-to-one and inflating the side branch. So you have to be quite careful. And then there is this concern about abluminal polymer disruption as well. But I did mention that we're doing some electron microscopy work just to show the effect of the various techniques on the actual polymer. What are the benefits? It reduces plaque transfer, prevents carinal and plaque ship. It helps to keep the branch open. And it really increases the chance of just keeping to one stent and maintaining this provisional approach, which we know in the long term tends to portend good outcomes. So in summary, the gel balloon technique is an extension of the side branch wire protection. It may facilitate side branch protection and minimize the risk of acute side branch closure. It's compatible with 6 French guides, so you don't need a 7 French to do this. You can do 6 French, depending on the size of the side branch balloon. You need to be careful when you remove the balloon under angiography. Again, watching your distal wire, watching your guide that it's not diving in. There have been no cases of entrapment reported if the gel balloon is removed before the pot. And specialty pot balloons can facilitate a more distal and accurate pot and permit correction of the JBT minor stent deformation. Thank you very much. Hope that's useful.
Nice. Very nice technical presentation. I enjoyed it a lot.
Me too. Thank you. Dr.
About
Mohammed.
half an hour just to try and keep it to time. And, I'm happy to have some discussion. And if anyone else has questions, we can.
Yeah, very nice presentation, Bharat. I really enjoyed. I have one more question. Um, do every sizable side branch need gel balloon technique to save the side branch, or it is something like angle based? So some branches are very difficult to renegotiate, like a 90-degree or more than 90-degree angle, sometime having a retroflexo region. So what do you think regarding angle of side branch and
Yeah,
further?
that's a very good, very, very good point.
Yeah.
I think if you've had a lot of trouble to get into the side branch, then you want to minimize the potential risks of that side branch actually getting more pinched off or actually losing that side branch. So it's something that I might employ. My cutoffs usually are about 3. If the side branch is about 3 millimeters and under, I would probably use a gelled balloon technique of some sort. If it's more than 3 millimeters, then, technically you should do what the EBC suggests. So you do a provisional strategy pot. If you need to recross and kiss, then I think recross and kiss. Because once you're getting above 3 millimeters in terms of size, I think you're dealing with much larger territory, much larger vessels. There are some little caveats. The case I showed you, I mean, this was a guy with the STEMI. You didn't want to fiddle too much. And I really wanted to make sure that the side branch, I had treated it with the drug-coated balloon. I just wanted it to not get pinched. And so that's why I employed it there. But really, I had converted a moderate to severe osteocirc disease to a mild to moderate disease. And then a simple provisional approach, which I thought an enhanced technique like a uninflated gel balloon might help to prevent any pinching, which it did. So I employed it in there. But most of the time, if you're dealing with larger branches, I would probably provisional with a wire across, recross if needed, kiss plus minus DCB, and then repot.
Yeah.
Like you said, if you have a lot of trouble getting into the side branch and you don't want to stent it or you don't want to treat it, so you don't want to pre-dilate and then DCB it. If it's, say, a 2-5 vessel, there's less than 50% plaque at the ostium, it's not a true bifurcation per se, but you've had a lot of trouble getting into it, then this is a
Yeah.
good technique to employ for that situation.
Exactly. Yeah, I agree.
Very nice. Any other question?
If there are
No?
no
So thank you,
questions.
Bharat. It was very clear, and there are advantages in using this technique.
Yeah, it's
As
just
we underlined, this is an advanced technique for dealing with bifurcation, with some potential advantages as compared to just a protection with a wire. And I think that from this lesson and the discussion and interaction and the cases that you presented, we all came out with some new expertise and a willingness to try this technique in some important bifurcation with an important side branch that we don't want to lose.
Yeah, one of the things I didn't really mention is what happens if you do get pinch side branch, even though you've put the balloon there. So one thing you can do is just inflate the side branch slightly, leaving the stent balloon there. And then you get your flow back, and then you've got time to work out what you need to do, recross and kiss. So
in this case, I would inflate it at like 2, 3, 4 atmospheres, so that at least the first
absolutely,
one.
just to get the flow back.
Yeah.
You don't want to cause too much deformity. So what I always do is I always leave my stent balloon in. Once both balloons are down, I check the flow. And if I see some pinching of the side branch or there's compromise of the side branch, I'll go 2, 4 atmospheres on the side branch balloon. And then you can always go up on the stent balloon to kiss. And when you kiss, then you have restoration of that side branch flow. Then you can remove both and then recross and kiss if you need to.
Yeah, exactly. So that does not substitute the final kissing. That this is very important because you have the wire out of the stent, and that's very important. And you leave this additional technique only in the case that after stenting the flow is zero or very impaired in the side branch, or you are unable to cross it with a new wire. And which is the wire that you prefer to use to recross?
For me, I mean, I use the Asahi wires a lot. So we use Sion Blue, the Sion, or
So no
sometimes
polymeric. No polymeric.
Yeah, no polymeric. Yeah, sometimes I mean, if it's a difficult cross, you might need to use a Sion Black. The other thing we tend to do is we have dual lumen. So we would put the dual lumen into the main vessel and then use the side port to try and cross over.
Yeah.